All right. Well, hello and welcome everyone to another Ask NEI, an exclusive live Q&A forum where NEI members can get their questions answered. I'm Dr. Andrew Cutler, Chief Medical Officer of NEI, and as you can see here, I am not at a beach in Florida. I'm actually in an airport. I'm traveling, and that explains this great facial covering that I'm modeling for you today. Because I'm in an airport, I have to keep a face mask on at all times. So I hope you can hear me. We've got some pre-submitted questions I'll be answering, but feel free to leave comments or additional questions in the chat box. This month, we'll be answering questions on all things depression. If I don't get to your question today, don't forget to attend NEI Synapse, which is this Saturday morning, where myself and Dr. Joe Goldberg will be covering those topics in more depth. And as NEI members, of course, you can all register for free. And it's not too late to register for Synapse. Please go to the NEI website and you can register. Okay, we have a number of really great questions today. So let me just jump right in and get started here. First one is, how long should a medicine be tried in an adolescent before considering a switch and assuming there's no major side effects? Great question. I don't know the data on adolescents specifically. I know for adults, there's very clear data that you should be seeing at least a 25% improvement in the first 2 weeks. Now, this is very different from what we were traditionally taught. We used to be taught that you should wait 4 to 6 weeks before making a decision about switching or changing. Now people say at least a 25% improvement in the first 2 weeks. And then if not, you should do something. And that something is, of course, debatable, whether it's switch, augment, consider raising the dose, things like that. But I would say that 2 weeks is probably too short really for an adequate trial to really tell in an adolescent. So probably, again, maybe 4 to 6 weeks. But what you don't see is someone going several weeks and then all of a sudden responding. Usually response is a gradual, continuous improvement over the first few weeks. So if you're not seeing that pattern, I would say it's time to consider a switch. Okay, is there a risk of MDD, depression mood relapse, when switching from a first-generation antipsychotic to cariprazine, as the latter is a partial agonist with a long half-life? Well, I'm a little confused by this question. For MDD, I wouldn't be using a first-generation antipsychotic. So I'm not sure if the person's talking about bipolar. And even then, I wouldn't use a first generation to treat any form of depression. First generation antipsychotics can induce depression. They're blocking D2 and not doing much else. They're not binding to serotonin receptors, for instance. Now, if you're talking about MDD and you're switching from a second generation antipsychotic to another one, well, the issue with cariprazine is not only long half-life, the D2 partial agonists, which is aripiprazole, brexpiprazole, and cariprazine, all have very high affinity for the D2 receptor. So if you're switching from a non-D2 partial agonist, for instance, you're going to kick that thing right off the D2 receptor if you add a D2 partial agonist. So that would be one thing to consider. The other thing is the long half-life does not mean it takes a long time to get to efficacy. So if you're worried about switching and a relapse during the switch, you know, you can always overlap a little bit and do a cross titration, but you're probably okay because these drugs do start to work certainly within the first week or two. So, you know, if you want to overlap for the first week or two, that's fine. Sorry, I don't completely understand the question. There's a little bit of internal inconsistency there, but I hope that answer was helpful anyway. Should an antidepressant, let me see here, should an antidepressant be continued with an adolescent who has suicidal ideation? Okay, great question. Obviously, what we're getting at here is that bolded boxed warning that was added to all drugs with antidepressant efficacy. Notice I'm not saying all antidepressants. I'm saying all drugs with antidepressant efficacy because some of the second generation antipsychotics, which we would not call antidepressants, but some of them have clearly demonstrated antidepressant efficacy, such as quetiapine, lorazepam, cariprazine, and now even Caplyta, which is not lorazepam. Oh God, I'm blanking. Lumateperone, thank you, lumateperone. They all have demonstrated antidepressant efficacy. So they all have the black box warning, as do traditional non-mood stabilizing antidepressants. And it's a long story here, but basically where it comes from is doing meta-analysis mostly of SSRI trials in children and looking at the younger adult population, and the warning really applies to under the age of 25. And it was noticed that there was an increase in suicidal ideation and behavior, but not completed suicides. And so the FDA slapped this black box warning on all drugs with antidepressant efficacy, even though drugs like second generations that I consider mood stabilizing antidepressants probably decrease suicide risk. And probably part of the reason why is if your first episode of depression is before the age of 25, that triples the odds that you're actually bipolar. And so what happened was in these studies, anybody under 25 is by definition at risk for bipolar. So a lot of these people were probably unrecognized bipolars, and they were being put on traditional antidepressants like SSRIs. And of course, what happens if you put a bipolar on monotherapy with an SSRI? It's either not going to work or it's going to make them worse. And in either case, you can have suicidal ideation coming out. So really, I think what this warning says is to screen all depressed patients very carefully for bipolar disorder. And probably I would use, if you think it's bipolar, I'd use a second generation antipsychotic that is FDA approved for bipolar depression, even though those carry the warning. There is actually some evidence they may lower suicide risk in patients with bipolar depression specifically. So that is a long-winded answer. Now to get to the specific question, should an antidepressant be continued in an adolescent who has suicidal ideation? Well, by definition, if they're an adolescent, that means that they're at higher risk for bipolar because anybody with their first episode of depression before the age of 25 has triple the odds of being bipolar. So I'd want to know a lot more. I'd want to screen that patient really carefully for bipolar. I want to know family history. I want to know previous response to medications. I want to know any comorbidities. I just would want to know a lot more. And if I got any whiffs of bipolarity, I'd really be considering a mood stabilizer or a second generation antipsychotic with antidepressant actions. So, that's it. Now, interestingly, when that black box warning came out, since then, of course, a lot of pediatricians and primary care docs have really backed off. The amount of prescribing antidepressants to children and adolescents dropped dramatically. And guess what? The suicide rates started to rise. So clearly, we are undertreating depression now in this population, and this is the law of unintended consequences from that black box warning. So that's a long-winded answer. I think antidepressants should be used if you're very comfortable that you've ruled out bipolar, and even so, I'd watch very closely to see what's happening, and I would really consider treating them as a bipolar patient if I got any whiff that the antidepressant wasn't working or was making them worse. So if the antidepressant, though, has helped the patient and they have suicidal ideation, that's a little bit of a different story, I would say. All right. Next, at what laboratory threshold do you discontinue or switch an antipsychotic? Well, it depends on the laboratory threshold. Obviously, what we're talking about here would be metabolic disturbance or prolactin elevation. Those would be the major labs. Or white count. That's another one. So let's take them individually. So we're talking about metabolic disturbance. Obviously, we'd be looking at glucose, triglycerides, cholesterol. I don't know that I have a specific cutoff or number for those values, but what I would say is it's always an assessment of the potential benefit and the potential risk. If you have a patient who really is very brittle and has had a lot of serious mood episodes that are high risk for aggression or suicidal ideation, and you've tried other meds and the one that they're on is the one that works best, but it's starting to cause weight gain or metabolic problems, that's a different situation from someone who maybe has a lower risk clinical picture, hasn't tried a lot of others, so you can switch. Certainly, I want to counsel all my patients about the importance of diet and exercise to try to mitigate this. You certainly would consider adding metformin. If you heard my talk recently about metabolic side effects and what to do with the atypicals, metformin has the best evidence, so you certainly can add metformin. And you can certainly use a statin if you need to for cholesterol and lipids, but certainly a very real world problem. And again, it's got to be balancing out the potential benefit and the potential risk of the specific treatment. We do have many options now that have lower propensity for weight gain and metabolic disturbance, such as lumateperone, lurasidone, cariprazine. Those are all really good options to consider. Now, let's talk about prolactin elevation. Prolactin elevation is interesting. They're really the only ones that I really worry about prolactin elevation, to be honest, are first generation antipsychotics, risperidone, and paliperidone. Those are the ones that really elevate prolactin, and they do it in pretty much every patient. And what's amazing to me, because I do clinical trials and we measure prolactin in almost every patient, basically, there's a lot of patients with elevated prolactin who don't have clinical signs or symptoms. They don't have gynecomastia or galactorrhea. It's really surprising how often that happens. So you can't just rely on clinical symptoms or signs to know if prolactin's elevated. What I can tell you is if they're on a first generation or they're on risperidone or paliperidone, they've got elevated prolactin, and it's very high. It's going to be 90 or 100 points up. That's not good in the long haul. It's not good to have someone with prolonged elevated prolactin over years. That's been associated with osteoporosis, metabolic endocrine disturbances, certain types of tumors and cancers, cardiovascular disease. So if that's the case, you might want to consider an option that doesn't elevate prolactin, and that's really most of the second generations other than risperidone and paliperidone. The amount of prolactin elevation in the others is pretty minimal. I don't usually get too excited about prolactin elevation until it's going up at least 30 or 40 points, to be honest with you. Remember that the D2 partial agonists, aripiprazole, brexpiprazole, cariprazine, they don't elevate prolactin. In the case of aripiprazole and cariprazine, they actually lower prolactin. And that's a trick you can use. You can add a little low-dose aripiprazole to, if somebody such as risperidone does have elevated prolactin, you can add a little low-dose aripiprazole and you'll drop the prolactin that way. Now, as far as the CBC and white count, it's pretty clear that an ANC, an absolute neutrophil count of 1,000 is sort of our threshold. If you go below that, that's when you really need to be careful or switch. So I hope that helps you think through a little bit some of the lab values. And I just want to remind you, in my training, I'll never forget, I had a professor who said, treat a patient, not a lab. So in other words, just because you see some numeric lab value that's a little bit abnormal, you want to take into account the clinical situation of the patient, their medical risk, again, how sick they are, the consequences of inadequate treatment of their illness and how well they're doing with this medication, and put all that into the hopper to make that decision. It's a clinical decision. Great question. All right, what is the mechanism, perhaps downstream, of SSRI-induced dyskinesia in adolescents? Okay, well, first of all, it is important to realize that SSRIs have been reported to cause dyskinesias. They can also cause akathisia. The simplest answer really is that these neurochemicals all talk to each other. And serotonin receptors don't just live on serotonin neurons. They also live on dopamine neurons. And so interactions with serotonin, the serotonin system, are going to have consequences on the dopamine and the norepinephrine system. So if we're talking first about dyskinesias, we're talking about dopamine. And one of the things we know is that if you raise serotonin, you can downregulate dopamine in certain parts of the brain, but you might increase it in certain other parts of the brain. And the point is, what dyskinesia is basically is an imbalance in the dopamine system. It's an imbalance in the direct and indirect dopamine systems. So the direct dopamine system, let's put it this way, when I want to curl my arm like this, right? Two things have to happen. I have to contract my bicep muscle, but I have to relax my tricep muscle. So the direct dopamine system is contracting the muscle. The indirect is relaxing the opposing muscle. And so you've obviously got to have coordination and a balance between those two systems in order to have smooth, coordinated, efficient movement. So anything that disrupts that balance can potentially cause dystonias or dyskinesias. And that includes raising serotonin, such as with an SSRI. Now, what's interesting is if you think about it, we give a lot of people antipsychotics, but they don't all develop TD, which clearly means there must be genetic predisposition to dyskinesias in certain patients, and we don't know who they are, unfortunately. We do know there are certain risk factors that you may be aware of that put somebody at a little higher risk for TD, and that includes age over the age of 55, especially postmenopausal females are a little higher. Mood disorders have a higher risk than psychotic disorders. Concomitant substance abuse, concomitant neurologic trauma, such as a closed head injury, traumatic brain injuries. There are various things like that that put somebody at higher risk. With an adolescent, the adolescent brain is a little different from the adult brain. It is developing. The dopamine system is obviously not as well developed because the frontal lobes don't fully develop, and the dopamine system doesn't fully project into the frontal lobes until you're into your 20s. So we may be talking about a different dopamine system and a different propensity to develop dyskinesia. But that's a long-winded answer to basically say that any drug that's affecting serotonin can theoretically affect the dopamine system, especially in SSRI, where you're really raising dopamine everywhere, and you're clearly going to have effects on both dopamine and norepinephrine as well as serotonin. Now, I didn't talk about akathisia. Akathisia is not so much a dopamine issue, or it is partly a dopamine issue, but it's also a norepinephrine issue. And where akathisia comes from is an imbalance in the dopamine and norepinephrine system in the nucleus accumbens, which is part of the ventral striatum, not the basal ganglia. And the basal ganglia sits right next to the nucleus accumbens, and they crosstalk and have communications. Turns out if you decrease dopamine, the nucleus accumbens has a core and a shell. Dopamine is mostly in the core. The shell is norepinephrine, and that's what communicates with the basal ganglia. So if you decrease dopamine in the core, what happens is you disrupt the balance and you get more norepinephrine transmission in the shell, which then stimulates the basal ganglia, and you get that sense of akathisia. So that's why the treatment for akathisia is a beta blocker, not an anticholinergic. Beta blocker is blocking beta norepinephrine receptors. So you're decreasing the norepinephrine tone to balance out the decreased dopamine tone, just like an anticholinergic for EPS or dystonia is dropping acetylcholine to match the decreased dopamine tone. Okay, long-winded answer, but I hope it's helpful. Okay, next, what do you think about, or what is your opinion on adding buspirone for antidepressant-related sexual dysfunction? Very good question. It has been tried. There is some data that it can help. Certainly, it's very reasonable. Buspirone is kind of a weak 5-HT1A partial agonist. There are others that have much stronger agonism. Vortioxetine is obviously a medicine that has built-in strong 5-HT1A agonism. So you could certainly use that. But it's certainly very reasonable, and it definitely can work. So it's certainly reasonable to consider. The other one is vilazodone, of course, that has very strong 5-HT1A affinity, and it's a partial agonist. So those two, obviously, vilazodone and vortioxetine don't have much sexual dysfunction, probably because of that 5-HT1A stimulation. So buspirone is very reasonable for that. Okay, when do you decide to just keep on increasing a dose versus switching or augmenting it 4 weeks? Again, very important clinical question. And what I would say is, first of all, there is a wide variety, a wide variability in people's metabolism of antidepressants. The obvious one, of course, is cytochrome P452D6, which is genetically variable. About 10 to 14% of the population are poor metabolizers at 2D6. But there's many other sources of variability in response and in the need for dosing with antidepressants. And that includes other enzymes that may metabolize the drugs, other CYP enzymes, and other enzymes outside of the cytochrome P450 system, such as UGT and others. But also there's a whole family of transporter proteins called PGP, which is phosphoglycoproteins. Those are transporters both in the gut and at the blood-brain barrier. And their job in life is to try to get rid of toxins that we accidentally consume. In other words, if you swallow a toxin at the level of the gut, and let's say it gets absorbed, the PGP protein is there to pump it back out again into the lumen of the GI tract so you don't kill yourself. Also, if something that's not good for the brain slips past the blood-brain barrier, there's PGP proteins to pump it back out again. Those things, some drugs are substrates for PGP proteins. So obviously, if they get pumped out of the brain, you would have to use a higher dose. And some PGP proteins are highly genetically variable. So some people have faster PGPs that are going to pump the drug out faster. Well, they're going to need higher doses of a drug if it's a PGP substrate, and not all of them are. And obviously, if your PGP proteins are slower, it would be lower doses would be needed. So my point is, and also, sorry, there's probably genetic variability in the pharmacodynamics, in the receptor binding, and what happens when you bind to receptors. Certain people are genetically more sensitive to certain receptor binding. A good example is antihistamine. People are very genetically variable with respect to histamine blockade. And let me prove it to you. If you give a room full of 100 people Benadryl and antihistamine, 10% of them will get snowed. They'll sleep the whole next day. They're very sensitive. A different 10% get the opposite. They get wired. And then 80% are in the middle. So there's genetic variability in receptor binding, and that may contribute to variability in your dosing needs. Okay, long-winded answer to get to the question, which is some people need higher doses, basically. Now, you can do genetic testing and see if somebody is a fast metabolizer at certain enzymes, but you also use your gut and your clinical judgment. And I often ask people, in general, are you sensitive to medicine, or do you need higher doses of medicines? And sometimes they can tell you. So also it depends, of course, on the doses that have been studied of a drug and how much of a range of approved doses. Do you have room to go up and go up and go up? Okay, now let's balance that out with what I said earlier about response and how long it takes to see a response. As I mentioned, you should see at least a 25% improvement in the first 2 weeks with an antidepressant. If you don't, it's time to do something. Unfortunately, the data is not clear on what that something is. Should I switch? Should I augment? Certainly, you should raise the dose if you feel like they're tolerating it well and not having side effects. If you're starting to see side effects, then raising the dose is less of an option, of course. Now, there is some clinical lore about whether I should switch or augment. And the issue is if I've got a partial response and I don't want to lose that response, that's when you may augment. If you're really not seeing much of anything or you're having intolerable side effects, that's when you consider switching. So hope that helps with that clinical dilemma. Next, I have a high-functioning, educated, insightful patient, excellent historian, strong family history of bipolar. She denies any personal history of mania or hypomania. Would you skip traditional antidepressants altogether because of her family history? That is also a great question and very clinically relevant. And I would say I would have a very, very low bar to use a second-generation antipsychotic if she's depressed. So I love that you've said traditional antidepressants. As you heard me say, I use the term traditional non-mood stabilizing antidepressants for the reuptake inhibitors, SSRIs, SNRIs, and all the other antidepressants. And I use the term mood stabilizing antidepressant for the second generation antipsychotics that have demonstrated antidepressant efficacy. All antipsychotics work about as well for schizophrenia. They're all antipsychotics, but they're not all antidepressants, so they don't all have antidepressant efficacy. So I would want to use one that has demonstrated antidepressant efficacy. And again, that's particularly quetiapine, lorazepam, cariprazine, and lumateperone are the ones that have the clearest established antidepressant efficacy for bipolar disorder. Aripiprazole and brexpiprazole are approved as augmentation for unipolar MDD. They're not approved for bipolar depression. So what I would say is, boy, I would be very, very careful about using an antidepressant and certainly using one by itself in a patient like this. I'd probably really consider a mood stabilizing atypical antipsychotic. Maybe this patient would get one shot at an antidepressant, and if it didn't work or it made them worse, I would just switch over at that point. So great question. More and more, the other thing I would do is I would dig a little deeper too. Look for the other clues of bipolar. In other words, early onset depression, remember, before the age of 25 triples the odds. We've already got family history. That's a big one. We want to look for if they've ever been on an antidepressant before. Obviously look for non-response or worsening. Postpartum depression, severe psychotic postpartum depression. So I'd want to know the gestational history of this woman. Another comorbidity that's suggestive is migraine headache with depression is 2.5 times more likely to be bipolar than depression without migraine headache. I'd also want to know if there's any comorbidities. The most common comorbidity is anxiety and substance abuse. And I'd want to know about any possible mixed symptoms. So even though she doesn't have a history of mania or hypomania, how about in the current depressive episode? Are there any symptoms of mixed features? Because mixed depression, almost definitely you're going to use a second generation antipsychotic. Okay, and that comes from our friends Roger McIntyre and Steve Stahl have talked a lot about that. All right, well, let's move on. Great question. For patients who are failing antidepressant monotherapy, is there a preferred adjunctive class such as SSRI, SNRI, NDRI, TCA, atypical antipsychotic mood stabilizer, supplement, T3, TMS, et cetera? Boy, you covered the waterfront there. Well, what I would say is the best database we have by far is the atypical antipsychotics, and especially a few of them that I mentioned that have the antidepressant efficacy. So I think that those are the ones that have the best efficacy database. Obviously, you have potential tolerability and safety issues. You've got the risk of TB. There's somebody behind me. You've got the risk of TD, you've got the risk of weight and metabolic issues. So you've got to be aware of that. Now, it is very reasonable to consider thyroid hormone and lithium, which have a long history. Certainly, if you feel like somebody is in the bipolar spectrum, lithium is very reasonable. I'm sorry, again, I don't know if you can hear the guy behind me. He's talking really loud. Let's see, what are the other options you talked about? As far as supplements, there aren't a lot of supplements that have great evidence. N-acetylcysteine and SAMe do have some evidence, of course. There's minocycline, which is the older antibiotic that has some evidence of augmentation, can be very helpful, but it comes with a lot of risks. So I think the preferred go-to is, and actually, if you look at America, the most common augmentation is bupropion and NDRI. If you go overseas, the most common augmentation is mirtazapine or a tricyclic, actually, much more than bupropion. So hopefully those are helpful. Lamotrigine also does have some antidepressant efficacy, but again, if it's unipolar MDD, by far the best evidence is adding an atypical antipsychotic second generation. Now, always, 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 when you see somebody failing an antidepressant, a traditional non-mood stabilizing, please dive deeper into bipolar. Please screen for bipolar, because that's a depression that you treat differently, as you well know. Okay, how about the choice of antidepressants in pregnancy? Great question. We've had a number of lectures at NEI on that. And really the issue is the SSRIs are probably safe in pregnancy. So I would probably go with an SSRI that has the best database. For more information, you can certainly go to the NEI website and look at some of our archived talks from Marlene Freeman and others. You can go to Stahl's Prescriber's Guide. He talks a lot about that too. All right, can I comment on antidepressant-induced tinnitus or tinnitus? I never know how to pronounce that word. Is it tinnitus or tinnitus? And what options can you recommend? I am not an expert on that. I don't have a lot of experience with that. I think tinnitus is not well understood in general. There certainly are some treatments. I'd have the patient go to an audiologist. And there again, you've got to do a potential benefit risk. If this antidepressant is saving their life, you're going to keep them on it and try to figure out a way to deal with the tinnitus. If not, you can try switching and see if switching might help the tinnitus. We now have antidepressants with a lot of different mechanisms, so certainly switching. So I'm sorry I don't have a much better answer than that, but I know audiologists. I went to a talk once by an audiologist. It was fantastic. There are some newer treatments for tinnitus. Okay, is there evidence that serotonergic antidepressants with multiple targets, such as vortioxetine, have less or more risk of manic switching or rapid cycling in bipolars than SSRIs? Well, first of all, if you know a patient is bipolar, I would avoid traditional non-mood stabilizing antidepressants if you can at all help it. The real question is, someone who you haven't recognized as bipolar, what's the risk of switching them if you use these? Well, SSRIs have pretty low risk of switching, actually, into mania. They can make people more subtly worse, a little irritable, a little anxious, a little bit of insomnia, but switching into full-blown mania, that's more common with the tricyclics. I can't say that there's less risk with vortioxetine, but what I can say is it makes sense to me that there would be, and that's because to be an SSRI, you want to block 80 to 90% of the serotonin transporters. Vortioxetine only blocks about 60 to 80%. And so some of the efficacy, it can't all be from SSRI. Some of it is from those receptor bindings, but you're blocking less serotonin transporters. So in my mind, you're doing less increasing serotonin throughout the brain, less blasting of serotonin. And so in my mind, maybe it would be a little less likely, but I can't say that there's data comparing the two. Okay, what is your experience? We're getting close to the end here. What is your experience with Nuedexta and depression? I have 5 patients who are doing significant antidepressant benefit. Absolutely, no question about it. Nuedexta is dextromethorphan. Dextromethorphan is an NMDA antagonist, but the problem is if you just take dextromethorphan, it gets immediately metabolized to dextrorphan, a different animal which doesn't work the same way. Dextromethorphan is an NMDA antagonist like ketamine, also sigma-1 receptor agonism, which is an antidepressant effect, modulates glutamate, and it has some SRI qualities. So on paper, dextromethorphan is an antidepressant, and there is now in development AXS-05. If you come to Synapse this Saturday, you'll hear a poster on AXS-05 from Axsome That is dextromethorphan plus bupropion to take advantage. Bupropion blocks the CYP2D6, so it prevents dextromethorphan from being metabolized to dextromethorphan and hangs around longer. And you get the benefit of dextromethorphan plus the added synergy of the antidepressant actions of bupropion, which is NDRI. Oh boy, we have other questions, and I'm so sorry I didn't get to the questions that we have in the chat box. But guys, we've run out of time. Please come to our session, the Synapse this Saturday. Please ask some of these same questions. Type them in. Joe Goldberg and I will have a lot more time. We can address some of these questions. Thanks so much. It's been wonderful talking to you again. Safe travels.